Good afternoon, everyone, and welcome to the webinar. My name is Amanda Hooper, and I'm from the National Women's Law Center. I have just a couple quick housekeeping notes before we get started today. First, all lines will be on mute during the presentation, but you can submit questions at any time, either by entering them into the function in your webinar toolbar and submitting them, and then we'll get to them at the end. Or at the end of the presentation, we'll also have the ability to open up the phone lines, and I can share more information about how to do that with you a little later on. Please also note that you'll receive a link to the recording of this webinar afterwards. And without any further ado, I will turn the floor over to Gretchen Borschelt, who is Vice President for Reproductive Rights and Health here at the National Women's Law Center. Gretchen, take it away.
Thank you so much, Amanda, and hi, everyone. I'm so happy to be here with all of you today to talk about the Affordable Care Act's birth control benefit and hopefully tell you everything you need to know about the benefit and what your patients should be getting from their insurance coverage. I want to thank Upstream so much for inviting us to be here with all of you. They're such a great partner and doing such important work in Delaware and across the country, and we're really thrilled to be able to partner with them on this. So I'll just go ahead and get started. And as Amanda said, we hope that we'll have plenty of time to wrestle with any questions you have or any problems that have popped up for you. And I'll do my best to answer them. And if there's any reason I can't, then we'll be sure to put you in touch with the right people who will be able to help you. But our goal is to tell you as much as you need to know to anticipate any common problems and to be able to make sure your patients get the birth control method they need. Okay, so let's go ahead and get started. So as Amanda said, here's a picture of me. I'm Gretchen Borschelt, the Vice President for Reproductive Rights and Health at the National Women's Law Center. For those of you who aren't familiar with the National Women's Law Center, we have worked for more than 40 years to protect and promote equality and opportunity for women and families in this country. And that means that we champion policies and laws that help women and girls achieve their potential at every stage of their lives, whether it's at school, at work, at home, in retirement, throughout their lifespan. And so for women, the birth control benefit that's part of the Affordable Care Act, we've really been very involved in every aspect of it. So we helped to get it in place in the law in the first place, and now we're making sure that it's working the way it should, and that includes partnerships like this where we get to talk to those of you who are on the front lines of birth control delivery to make sure patients are getting their benefit the way they should. So I'm really excited to join all of you today, and what I'm going to do first is just review what this webinar is going to talk about. So even though I'm going to be talking about the Affordable Care Act birth control benefit, I want to situate that in the bigger picture of the Affordable Care Act, just to give it some context, because we hear a lot of attacks on just the birth control benefit, but it's helpful to remember how it fits in with the broader law that's done so much for women in this country. So I'm going to do a big picture and then review really what is required under the birth control benefit, which says that plans have to provide coverage of birth control without any out-of-pocket costs. So I'm going to talk about what that means and break down the different components of it. Then I'm going to tell you a little bit about a hotline that we have called Cover Her, which is here for you and your patients, and talk about the resource that we provide to all of you. And then I'm going to walk you all through some of the common problems we encounter through Cover Her, what we hear from women, the problems they can continue to face, and give you a sense of what you might encounter and how we would solve some of the problems that we hear, and a few case studies to help us do that. So that's what we're going to cover today. And again, plenty of time hopefully for Q&A for all of you to ask any questions you have or anything that I don't cover in this webinar. So in terms of getting started and placing the birth control benefit in the bigger picture, it's worth remembering what insurance was like before the Affordable Care Act. Now, we know that prior to the healthcare law, the insurance market often failed women. And I have here an image of a woman symbol with denied over it, because we know that prior to the Affordable Care Act, plans could deny coverage to women for pre-existing conditions. And for women, that meant having been pregnant, having had a prior cesarean delivery, treatment for domestic violence or rape. All of those things could and did result in women being unable to even purchase health insurance in the first place. Plans would just turn them down. And we also know that plans would routinely charge women more than men. So if they were able to get coverage, if they didn't have a pre-existing condition, then they were told they had to pay more for the exact same coverage as a man. And they would often find out that the plan didn't cover what they needed, like maternity care. We did a study before the Affordable Care Act and found that only 12% of plans in the individual market covered maternity care. So women couldn't get the coverage they need. Now, when it came to birth control, there was clearly an unmet need. So prior to the law, we know that the costs of birth control when women were paying out of pocket made up 30 to 44% of women's total out-of-pocket healthcare costs. And you can think about somebody making minimum wage. This is a graphic we put together a couple of years ago around the Hobby Lobby decision that was in the Supreme Court, and it looked at what did it mean to a minimum wage worker, right? If she wanted an IUD, we know that the upfront cost of that could be around $1,000. So that is nearly a month's salary for someone working at minimum wage. It just is unaffordable. And you can look at the different costs of the ring and the pill. I mean, even 6 days of work could be unaffordable for some women workers. So what we know is that not having full insurance coverage led women to use birth control incorrectly, to use it inconsistently, or even to forgo it altogether. And that meant we had a higher unintended pregnancy rate in our nation. And of course, with unintended pregnancy comes risks to the health of women and children. And you all in Delaware know this better than anyone else, given that your state has the unfortunate distinction of having the highest unintended pregnancy rate. But not only did it harm women's and children's health, but it also meant that some women weren't able to move forward in their education and their careers because they couldn't prevent or plan and space their pregnancies. And so it hurt kind of our, economic security of women and families in the state and around the country. So this is why we love the Affordable Care Act. The Affordable Care Act has done so much for women. It solved the problem that women faced in terms of coverage generally and then coverage of women's services specifically. So the Affordable Care Act says that plans can't charge women more than men. It says that plans can't deny coverage because of pre-existing conditions. It says that plans have to cover the services women need, like maternity care. And it says that plans have to cover a set of preventive services without any additional cost sharing. And it's that fourth piece, the preventive services requirement, that we want to go into a little bit more. That's where the birth control requirement comes from. So in terms of the preventive services requirement, specifically, all new plans have to cover without cost sharing these buckets of preventive services. So you'll see here the list of them. And the first bucket is items or services that have an A or B rating from the USPSTF. That's the U.S. Preventive Services Task Force. So if something is rated in that way, it has to be covered by a plan without cost sharing. The second bucket is a set of immunizations that are recommended by CDC. The third bucket is a set of preventive care and screenings for infants, kids, and adolescents recommended by the Health Resources and Services Administration. And then the fourth bucket here in bold is a set of preventive services for women determined by HRSA. And that fourth bucket is where birth control comes up. But before we get to that, I just want to pause here and highlight one of the USPSTF rated A services in that first bucket there, because it's already come up in a prior webinar, and that is STI screening. So I know sometimes you all do STI screening as part of giving a woman her birth control. Well, there is already a requirement that screening for sexually active non-pregnant women at increased risk of chlamydia, gonorrhea, HIV, and syphilis infection, that already has to be covered without cost sharing. So that's separate and apart from the birth control benefit that I'm going to talk about, and I just wanted to flag that for all of you to keep that in mind going forward, that that also has to be covered without additional cost sharing. But getting back to the women's preventive services, that bucket of preventive services that have to be covered without cost sharing. You can see here there's a list of women's preventive services. This list has been determined by now 2 independent expert panels that these are the important women's preventive services that weren't otherwise captured in those other preventive services buckets, and that these have to be covered for women in all plans without cost sharing. You can see the list here. So contraceptive care is listed here alongside all of these other things, the well woman preventive visits, interpersonal and domestic violence screening, breastfeeding supports and supplies. So this is a quite detailed and nice list of things that plans have to cover specifically for women in their plans without cost sharing. Now, what does it mean when I talk about plans have to cover it? Which plans are we talking about? So any new plans that are sponsored by employers, and the word new means something here because there are some plans that have been grandfathered into the law, and they don't have to yet cover this preventive services. So if a plan existed prior to the date that the healthcare law was signed, which was March 2010, if it existed prior to that date and it hasn't made certain changes to its design and to other aspects of it, then that's considered grandfathered in, and it doesn't have to yet comply. Now, the thing is, the percentage of grandfathered plans is decreasing rapidly. We were at 72% in 2011. In 2015, that was down to 35%. So the number is dwindling, and we expect that soon there won't be any grandfathered plans left, but there still are some of them. And so I just want to flag that for folks that it could be that you're dealing with a patient who's in a grandfathered plan, and if that's the case, she won't have this coverage. And that's going to come up again later as we talk about some of the case studies. Plans that are purchased in the individual market also have to comply with this requirement. So those are plans that people purchase either on their own in the new marketplace, or they might purchase it outside the marketplace. And they sometimes purchase them through an insurance agent or a broker, or you can purchase directly from an insurer. But if it's an individual market plan, it has to comply with this benefit. And then individuals who are in the Medicaid expansion. Delaware has chosen to expand Medicaid, which is great. It reaches so many more women this way. And if you're a part of the Medicaid expansion population, you get this benefit and the no cost sharing in all FDA methods, which is important. So those are the plans that have to comply. I will just tell you, I'll make a note here to note that there's also a small subset of plans that don't have to comply, and those are plans of houses and other, churches and other houses of worship, certain religious employers. So if you are dealing with a woman who works for a church or a house of worship, then her plan might choose not to cover that because they have a religious objection and they don't have to comply with that. So I'll just note that as we move forward. In terms of no cost sharing, what does no cost sharing mean? It means no deductibles, no co-payments, no co-insurance. So it's across the board. A woman should not have to worry about cost for this service. She's paying her premium, and beyond that, she doesn't have to worry about paying anything else. Who has to be covered under this requirement? Well, it's all enrollees that are in the plan, and that includes dependent children. If the plan is offering coverage to dependent children, then they have to make sure that they get the preventive services without cost sharing. And of course, another great part of the Affordable Care Act is that individuals can stay on a plan until age 26, so we know that there are even more dependent children now who are getting that coverage through their parents' employer's plan, so that's great. Okay, so I want to now dig in a little more into the birth control benefit and the nitty-gritty of this requirement. And before we get into the specifics, I want to give you an example of some common questions that we've heard from healthcare providers, and I'll just kind of read them aloud. And we'll talk through what the answers are. So one says, I'm a scheduler in an OB/GYN office, and I have a patient. When I called on her benefits, they said her plan is not covered under the women's health care mandate. I was under the assumption that this is not correct. How can I find out for sure? The second one says, under the ACA, which is the Affordable Care Act, shouldn't birth control pills be available without copay, or do they have to meet their deductible first? And then the third one is, we've had some insurance claim denials on implants and Nexplanons, the particular policies involved, purchased through the exchange program. The insurance reps are saying that the devices fall under their deductible. Do you have any recommendations? And so in all of these cases, unless it's a grandfathered plan, which is the first thing that we have to figure out, yes, they should be getting this coverage for all of these birth control methods, and they shouldn't have to be paying anything. They shouldn't have to meet deductible. They should be covered. And so I'll talk now about why that is and what the requirement actually says. So the first thing to know is that the requirement says that plans have to cover all FDA-approved methods. And you see here a link. That links you to the FDA Birth Control Guide, which is where we get the list of methods. Now, you don't have to go to that link right now because I actually have it on the next slide. Here you can see the categories of methods that the FDA has listed that have to be covered without cost sharing. So you can see them here. There's 18 method categories for women that have to be covered. So you see sterilization surgery for women, sterilization surgical implant for women, rod, IUD copper, hormonal IUD, those are two separate categories, shot injection, the patch, ring. There are 3 categories of oral contraceptives, the combined pill, progestin-only pill, and the extended continuous use pill. Then we have the diaphragm with spermicide, the sponge with spermicide, cervical cap with spermicide, female condom, spermicide alone, and then 2 categories of emergency contraception. One for I can't say it. Okay, one for Plan B and other similar kinds, and the second for Ella, which has its own method category. So you see here, these are the 18 method categories that have to be covered by a plan under this requirement. Now, it's important to note that all does not mean every. So plans do have some leeway. Now, what that means is they can't exclude a method entirely. So they couldn't say, we're not going to cover the patch. Well, no, we just looked at that list, and the patch is a separate method category, so they have to cover it. But what it means is within those method categories, they can exercise some medical management. So, for example, in the category of hormonal IUDs, they can choose to cover only one of them without cost sharing. So they might choose to cover Liletta. But for a different category, if there's only one, then they have to cover that specific method. It also means that plans can choose to cover generics instead of brand names, and that really plays out in the context of the pill, right, where we have so many generics that it could mean that a woman couldn't get the specific birth control method she needs, or seemingly couldn't get it. But an important point and what I want to talk about now is a way that's basically a workaround that actually does mean that all means every, and that's the waiver process. So the requirement says that a plan has to have a waiver process in place that makes sure that if a woman needs a very specific birth control product, she can get it. Her provider and she decide that she needs that birth control product, whatever it is and whatever category it fits in, even if the plan doesn't typically cover it or usually imposes cost sharing on it, she has to be able to get that particular method. And usually what this involves is the provider has to complete some paperwork on why that method is medically appropriate. And they submit that, and then the plan has to cover it without cost sharing. And what's really great here and really amazing is that in deciding whether it's medically appropriate, the plan has to defer to the provider's determination. And that can include things like severity of side effects, or the differences in the permanence or reversibility of birth control, the patient ability to adhere to the appropriate use of that item or service. So it's a pretty broad definition of medically necessary, and it's totally deferential to the provider, which is much different, we know, than other ways plans determine medical necessity. And this is not the prior authorization process. The prior authorization process, as I'm sure you all know, can be a real problem for patients. That's not what this is. We're talking about a different kind of process. And just as one example, say that your patient has had really bad side effects when she uses a generic version of the drug, but that's what's covered by her plan, whereas if she uses the brand name drug, she tolerates that. So you want to get that brand name for her, but if the plan doesn't cover it at all, if it imposes cost sharing for the brand name, then you have to use this waiver process. You have to be able to explain why that brand name is medically necessary, the generic won't work, and then she should get the coverage of that brand name drug without cost sharing. So that's the waiver process. It really is a workaround to make sure that all means every particular birth control product. So it's a great part of the law. So I also want to talk about another requirement, which is making sure that plans cover associated services. So they don't just get to cover the actual item or device, they actually have to cover the services that are related to follow-up and management of side effects, counseling for continued adherence, device removal. So the things that go along with getting the method itself have to also be covered, because we know that there are costs that are associated with that method, and that those associated services could keep certain methods out of reach for women, right? And that's exactly the opposite of what this law was supposed to do. So it's not just the device itself, it's everything associated with it. And that could include, for example, not only the IUD insertion, but clinically indicated ultrasound to confirm placement, removal, for sterilization, that means anesthesia and the confirmation tests. So it's beyond just the actual item or device. beyond any associated service. So I want to mention a couple other things that plans can do. One is that they can impose cost sharing if an individual has to go out of network for services. And this is important for all of you. If your clinic dispenses birth control pills, but the plans in network pharmacies or CVS or Walgreens, then you could find that the patient is told that they have cost sharing at the clinic. And so that's something to keep in mind, not only to make sure that you all are considered in network for these kinds of services, but also a problem that could come up that might need to be addressed. And then the other thing to know is that plans can require a prescription if an individual wants to get an over-the-counter method without cost sharing. So, for example, if they want to get emergency contraception that doesn't require a prescription, Plan B or one of the other ones, they might have to get an actual prescription in order to get that covered without cost sharing. So that is an overall of the benefit. Now I want to talk a little bit about our hotline and resources and go through some common problems and case studies. So we have a hotline called Cover Her, and you see here our little logo here, coverher.org. We also have a telephone number that will come up in slides as we move forward. And what we offer is one-on-one assistance to individuals who are having trouble with their birth control benefit. The plan's not covering what it should be covering, or they're having trouble with the waiver process, or they've been denied. We can help them figure out what's going on, and we can help them address it. So we have online resources of Q&As, of sample appeal letters. We have a script for calling insurance plans to find out if your plan is grandfathered, and we put all this information together in a way that's really easy to understand and easy to use. And we find that a lot of people are just using the materials that we put on the website first and foremost and don't often need to call us. The calls that we get are usually the trickier questions that maybe they can't figure out on their own. But for the first line things, many people are able to just use our resources on their own to find out what's going on and to question and demand a change in their situation. Now, in terms of what's on our website, I'm talking today about birth control, but I also want to mention that this hotline and our materials also reach women who have been inappropriately charged cost sharing for other kinds of women's preventive services. So we hear a lot about breast pumps, for example. We've heard about the well woman visit. So they're all part of the women's preventive services requirement, and they should all be covered without cost sharing, just like birth control. And so we have most of our materials about birth control, but we also have additional materials to help folks who are having trouble with the other parts of the women's preventive service requirement. So this is our hotline, this is our resource, and we know with any new law or requirement it takes some time to get to full compliance. We know that plans are certainly doing better now than they were at first when the benefit was initially passed, and but we know there are still some problems, and so I just wanted to highlight for you all some things that we're still hearing on Cover Her and that we're still seeing when we look at insurance plan documents. So one problem is still just the basic problem of women not getting their coverage without cost sharing. It might be because she's in a grandfathered plan, in which case we help her figure that out, and then we refer her to clinics that can help her with low-cost birth control services, or it might be that the plan is supposed to be covering it and they're just violating the law, and then we help her to appeal that and get that money back, or to make sure that the coverage comes through. So that's one problem we still hear. We are still hearing that plans are failing to cover the services that are associated with birth control without out-of-pocket costs. So they could be paying for follow-up visits or for the tests that they need. We hear this a lot around IUDs and implants. There was one woman who contacted us who was charged for both a pregnancy test and an ultrasound related to her IUD, which shouldn't have happened. And then another woman who contacted us who got a over $700 bill for ultrasounds when her IUD had to be replaced. And so those are the kinds of things that we can help a woman address and get the money back if she's already paid it, or get that changed if it's just a charge that she hasn't paid yet. We hear of women who are still having trouble with the waiver process. Either their plan doesn't have one yet and is violating the law and not having one, or the woman just can't find any information in her plan documents or from customer service representatives about how to access that waiver, and so we help her figure that out. Or sometimes women are told they should use prior authorization, and so we help them to educate their insurance company about how that's not appropriate, and in fact they should be using a different kind of waiver process that's deferential to the provider's determination of medical necessity. The next thing you see here is accommodation in quotes, and what that refers to are women who are in plans or have employers who are religiously affiliated, like a university that's religious or a Catholic hospital. So not the church or other house of worship that I mentioned earlier that gets out of it altogether, but this accommodated plan. And the Obama administration told these kinds of plans that are religiously affiliated, well, you can get out of providing it in your employer plan, but we still want the women to get the coverage. So the insurance company actually has to go directly and get it directly to the woman, not as part of her regular employee benefits, but separately. And for the woman, this should be seamless. She should have no trouble when she comes into a clinic. She should hopefully present the same insurance card she always presents, and it's all taken care of on the back end by the insurance company, which handles it separately from her employer-based claims. Sometimes a woman has two cards, so you might see that if she's in an accommodated plan, but it should be covered, fully covered, without cost sharing for that woman, whether she works for a religious employer or not, as long as it's not a church or other house of worship. And then the last category I would say is we hear from older women, women ages 50 and older, who continue to need birth control. It's not like as if when you turn 50, all of a sudden your reproductive capacity just shuts down on your birthday, right? Some women continue to need birth control to prevent pregnancy. And so we know that the birth control benefit is required for all enrollees. They have reproductive capacity, and some women who are older do. And so if a plan tries to implement some policy that says once you turn this age, you don't get this benefit anymore, that's just a violation of the law, and we've had to challenge that a couple of times too. So those are some of the common problems we hear. And now what I'd like to do is walk us through a couple of case studies of some of these problems and how to solve them to give you all an idea if you face this yourselves. So the first example I have is in private insurance, we have heard from some plans that they don't cover the ring. That what they say is, well, we cover other hormonal methods, and so we don't have to cover the ring. You can use the pill or some other hormonal method. Well, no, that's a violation of the law. As we saw on the list of method categories, the ring is a separate method category, and so that has to be covered. And so the next steps, if you hear from a woman who's facing this problem, is to determine, first of all, the question we always ask first, does the Affordable Care Act apply to your plan? Are you in grandfathered plan, or do you work for a church or house of worship? Those are your exceptions. If she does, then find another way to help her. But if she doesn't, then she should be getting this coverage. And so the next step would be to file an appeal. If that's not successful, go up to the next level of filing a second level appeal or second level review. And then if that's not successful, filing a complaint with the government agency that regulates the plan. And that's either the state insurance commissioner if she's in a marketplace plan, or the Department of Labor if she's an employer-based plan. And again, our hotline, Cover Her Hotline, is here to help you all figure that out. We have a flow chart on our site for a woman to call her plan and figure out if it's grandfathered. We have the instructions for filing an appeal, sample appeal letters, all of those things. But this is kind of an example of how we would walk a woman through the process if she faced this problem. Second example here, so this is in Medicaid, and I'm talking mostly about private insurance, but I did want to put in one Medicaid example because we've heard from some people on Medicaid that they face some problems. So in this circumstance, a woman on Medicaid is told that the plan covers hormonal IUDs only if you do prior authorization, but a copper ID you could get with full coverage right away. Well, that is a violation of the law. As I said, the Medicaid expansion, if she's in the Medicaid expansion population, they have to comply with the birth control benefit and its requirements. And we know that hormonal IUD is a separate method category and has to be covered without any prior authorization or anything else. So that would be something to challenge immediately. Now, if she's in traditional Medicaid, which doesn't have to comply with the strict terms of the benefit, we also know that there's language there that says that plans can't limit an enrollee's free choice of family planning method. And so I think there's a reason to challenge that policy as well. It's just slightly different what that would look like. And so the next step would be to challenge that policy and to file an appeal with the Medicaid agency or with the managed care organization. And so we can try and help with that. You know, specifically for Medicaid expansion population, we can help because it's the same as the benefit in private insurance. And so people can come to us for help with that. But if it's traditional Medicaid, we can also put people in touch with folks who could help them with that part of it too. So we are here for those on Medicaid just as we are for those in private insurance. And then the last case study I wanted to run through is an example of a denial of associated services. So here there's a problem of a patient being told that a hormonal IUD is the best method for her. Oh, I'm sorry, that was for the Medicaid one. For this one, it's the copper IUD is the best method for her. Your staff checks the coverage in the patient's plan and told the IUD is covered at 100%. The patient makes the insertion appointment, you order the IUD, the patient has IUD inserted, that's all covered 100%. But then the patient comes back because there's a bleeding pattern that is happening and gets the explanation of benefits saying that she owes money for the follow-up visit. And when she calls the plan, she's told that the IUD was covered at 100%, but the follow-up visit is not. That is a violation of the law. What we hear is that plan saying, oh, no, we don't have to cover follow-up visits. That's not a preventive service. Or, oh, yeah, we cover the device, the insertion, the removal. That's what we cover. We don't cover anything else. And those are violations of the law. It has to cover follow-up visits. And so, again, the next steps are the same. Determine if the Affordable Care Act applies, file the appeal, second-level appeal, and the complaint with the appropriate agencies. And we, as the Cover Her Hotline, are here with resources and assistance where you need it. So those are some examples, and I want to leave you all with the idea that it is worth going through this effort for individuals, not only to address the individual woman who has the problem, but also because they can change policy writ large. So what we often see is that one woman has a problem like not getting her ring covered, and by her advocating and getting that changed for her, they also change it for everybody in that plan. So it's important when there are these problems that we address them and we make sure that plans are aware that they're violating the law, because it helps not only the particular individual, but it helps everybody who's in that plan. And of course, the plans are using the similar plan designs across states. So it can not only help somebody in Delaware, but could help states in similar plans in other states. So we know that persistence pays off, and I have one quote here from a woman who called us. She was advocating on behalf of her daughter, whose Nexplanon implant was denied coverage, and she called us back and said she wanted to let us know that the insurance company finally paid the claim for her daughter's Nexplanon implant. And she had made follow-up phone calls. She had done a second-level review with the appeals committee. You can see here they hadn't responded. She was calling them, and she finally got the call back that told her that they were going to cover the claim under the preventive services benefit, and she wouldn't be charged any out-of-pocket costs. So it does pay off, but you do have to be persistent, and you all know this better than anyone dealing with insurance companies every day, that sometimes you really have to push them and stay on them, and that sometimes the first level person you talk to is not the right person, and you have to keep calling and keep asking for higher and higher people until you get the one who can actually handle the problem. So we are happy to help women do that, and happy to help all of you do that if you need it. So that's the benefit in the nutshell. I just want to take a moment to say, as I have you all here, and I'm sure you know this better than anyone, but really we always like to talk about what a game changer this benefit has been for women. So we know this benefit went into effect in August 2012, and over 55 million women are now eligible to get birth control without cost sharing. We know that it's saving money because women don't have that cost for birth control out of pocket. I'll give you some statistics on that in a minute, but this really is making a difference because cost is no longer an obstacle. And we know that women are making different choices now on birth control. They're choosing the more effective, longer-acting methods that traditionally have had the higher out-of-pocket costs. We know that some women, this is going to mean that they're going to use birth control for the first time, and they might be finding their way to you for the first time. We also know that for some women, they're going to be using birth control more correctly and consistently because they're able to get the method that they want and able to afford it if they need to, keep getting it like the pill. And so what we're hoping is that all of this is going to show in a reduction in unintended pregnancy, and that's going to have positive health outcomes for women and any children she has, and it's also going to have long-term effects for women and their long-term goals, like finishing their education and advancing in their career and anything else that they may want to do. So here's some actual data from our friends at the Guttmacher Institute on the way that the Affordable Care Act birth control benefit is working. You can see here the percentages of women who were paying out of pocket for all of these different methods before the ACA took broadly effect, and that's in the blue, and then after the Affordable Care Act took effect, spring 2014, you can see the differences here. And soon we're going to have 100%, I hope, in the orange category and 0% on women still paying out of pocket. And then also here's some other data about how the birth control benefit is working. As I said, it's saving women money. We know in 2013, just in 1 year, women saved $1.4 billion just on the birth control pill. So that's huge for women's bottom line and the economic security of them and their families. We know that women are filling their prescriptions, so there's been nearly a 5% uptick in filled prescriptions for birth control pills in 1 year. And we know from Express Scripts that they have seen insurance coverage use increase for birth control. So it increased 7.2% in 1 year's time. So women are using this benefit. It is there. It's meeting an unmet need. And it's important that we do all we can to make sure women are educated about it and using it the way they should be using it. And so I leave you all with a couple of resources here. There, again, is a link to our Cover Her hotline. I'm going to just keep reiterating that and keep reiterating that because we're here for you. But I also wanted to make sure you all have a link to a guide that we put together with some other groups. That's an IUD and Implant guide to reimbursement, which has information about billing and coding, which I know comes up a lot for clinics, and want to make sure that you know that that resource is there. So I will stop there and happy to take any questions or answer any comments or just hear what you all have to say about the benefit or how you've seen it work.
Great, thanks, Gretchen. So as a reminder to folks, you can either submit questions by text through your webinar toolbar, or in your toolbar you should see a little hand icon that says raise your hand. If you hit that, that will indicate to me that you want to ask a question over a phone line. And so I can let you know that I'll unmute your phone line and you can ask your question that way as well.
So this is Gretchen. I will, go ahead.
Nope, go ahead, Gretchen.
I was just going to say, I know that there were some questions that we got in the prior webinar we did, and so I'm happy to throw those out and answer those for folks. I meant to address them during my slides, but I forgot. So I'll mention a couple of things. One, we got a question of whether our hotline offers translation services, and we don't. So we're in English, and all our materials are in English. We don't have staff to support any other languages. But for English-speaking patients who need help, we are here for them, and we can try and help them find other help in other languages, but it's not something that we offer. And then another question we got was about whether if someone has to switch methods, does the benefit cover that? And the answer is yes, it should, because it covers the method you need, and it covers all associated services. And so if a patient tries a method and it's not working out for whatever reason, then it should not only cover whatever is needed to stop that method, like a removal, but should then cover the method that is needed for that individual to make sure that she's getting the birth control she needs without associated costs.
Okay. I don't see any hands raised. I don't know if anybody in the upstream office had questions that you wanted to ask, or if anybody wants to either raise their hand or send in a question over the webinar chat function.
Hi, Amanda. It's Enid from Upstream. We have a question on our end. Can an insurance company require that an IUD be inserted by a doctor and not a nurse practitioner or midwife?
So this is Gretchen. I think no, they certainly can't do that. I think in the Medicaid context, where I know that we've heard this question before, there might be some difference than private insurance, and I would be happy if it is in the Medicaid context. I'd be happy to connect with somebody who can look into that specifically for Delaware Medicaid and answer that question and see what they're requiring and whether that can be challenged.
Wonderful. We'd appreciate that. Thank you.
Great.
Maybe put out one last call for questions, either over the phone line or by text. Okay, well, it looks like no questions are coming in. I don't know if either the upstream folks or Gretchen, you have any things that you wanted to address before we close out for today?
No, we don't. Thank you for everyone's participation.
Yeah, thanks, everybody. I'm glad you were able to join. And if any questions do occur to you later, please don't hesitate to get in touch either with us directly through CoverHer or with the folks at Upstream who can connect you to us.
Thank you.
Wonderful. Thanks, everyone, for joining, and this concludes today's webinar.